I think that this would be a good time to go ahead and get started. We have, I believe, 5 scholars that we are going to be speaking with today. Before I turn this over to Dr. Jessica Khan, who will be introducing the scholars, I'm just going to do a few housekeeping tips. You will have questions for the scholars as you're listening to their talks. Please feel free to place those questions in the chat box, and we will get to the questions at the end of all of the talks combined, and that will give everyone an opportunity to speak, and then we will answer or ask the questions for the scholars at that time. If there's nothing else, I'm going to turn it over to Dr. Khan.
Good afternoon, everyone. Welcome to the K-Scholar Career Development Awardee Spotlight at CCTST Grand Rounds. We're very proud of our scholars who will be presenting today. I direct the KL2 program, and Dr. Jason Blackard co-directs the program. He's also on the Zoom call. And Krista Metz is our program manager. She's also on the call. She's absolutely wonderful. And you will be hearing from our terrific scholars today. I'm going to introduce all of them, and then they'll start their presentations. So first up is Dr. Charles or Chuck Varnell. He's an assistant professor in the Division of Nephrology and Hypertension at Cincinnati Children's. He'll be speaking on clinical systems to reduce acute rejection in pediatric kidney transplant. Next will be Dr. Ashley Devonshire. She is an assistant professor in the Division of Allergy and Immunology at Cincinnati Children's. She'll be speaking on phenotyping infants at high risk for peanut allergy. Then will be Dr. Laquita Jones. She is an assistant professor in the Division of Oncology at Cincinnati Children's, and she'll be speaking on a novel therapeutic strategy for refractory and relapsed FLT3 mutant AML. And then we'll hear from Dr. Joseph Perazzo. He is an assistant professor in the College of Nursing at UC. He'll be speaking about integration of telehealth assessment and HIV new intake. And finally, we'll be hearing from Dr. Sylvie Shaw. She's an assistant professor of medicine in the Division of Nephrology and Hypertension at UC, and she'll be speaking about sex disparities in cardiovascular health in dialysis patients. So thank you to all of our scholars for their willingness to present their work, and we look forward to seeing your presentations.
All right, I'll go ahead and get started. So I'm Chuck Varnell. Thank you for the introduction, Dr. Khan, and wanted to talk about research in the time of COVID-19. And so Dr. Khan had presented, the original title of this slide was going to be how we do our work to reduce acute rejection within kidney transplant patients. And so you may have heard either myself or my colleague, Dr. Hooper, talk before about this medication adherence promotion system that we had created here at Cincinnati. And the focus of the KL2 Scholars program that I've been in, or the grant that I wrote for, was to learn how to spread that throughout the Improving Renal Outcomes Collaborative, which is the kidney transplant learning health system that one of my mentors and partners, Dr. Hooper, founded and started here. And so a lot of the work that we have done has been related to that. And so we can advance forward. And next one. So the Improving Renal Outcomes Collaborative is a collaborative of 36 kidney transplant centers throughout the United States. And here they have a map, and you can see some of their logos. And as of 2019, we have data that 54% of all U.S. kidney transplants were performed at an IROC center. So we have a pretty good catchment area throughout the United States. And so I have been working on this. I've been continuing to work on this, but unfortunately, some of this work was halted about a year ago with the COVID-19 pandemic. And so one of my other career development goals is to learn how we can facilitate research and the spread of complex interventions throughout learning health systems as a learning health systems researcher. And so I actually pivoted for a short time from spreading the adherence work while everyone was focused on trying to optimize kind of COVID operations to ask some COVID related questions. And so if we go back to March 2020 and try to think about what did we know about COVID as kidney transplant docs, in general, we know that kidney transplant patients are at increased risk for infections, and they generally have worse outcomes, whether you're a child or an adult. And we knew that COVID-19 is this novel infection that's very infectious. And so, you know, that's probably a problem for our patients that we take care of. So when we think about things that we didn't know, in general, children seem to be spared from the more severe consequences related to COVID-19. So we probably were getting a better sense of that. Gosh, I don't know if it was probably around summer or late summer. But what about the patients I take care of who are on immunosuppression? And then what do we do with their immunosuppression? Should we be prophylactically reducing it? There was all this buzz about ACE inhibitors and what to do with those. And then lastly, patients and families wanted to know what to do with school and their siblings and who could they visit. So it was just, there was a lot that we didn't know at the time. And so we decided, well, let's ask these questions about IROC. So if you'll advance to the next slide. Part of what IROC does is it captures all the data and all the clinical information that's gathered during every clinic visit, including lab values, vital signs, other anthropomorphics. Then all that data gets uploaded into a central IROC registry that we have. And so all of that information was already available. What we needed to do was quickly create a way to collect COVID-related data. So we made a REDCap form that we sent out to all the IROC centers to collect IROC-specific testing data. And so we were able to publish the results of this. I think it came out in January, Journal of Transplantation. The time of the study was from April of 2020 through September 3rd of 2020. And if you go to the next, you can see that at that time, there were 3,000 patients in the IROC registry total. 22 of our centers at the time were able to participate in this study. From the 22 centers, they had 320 patients that were tested for COVID. It ended up yielding 280 patients that we ended up having the final analysis and clinical descriptions and outcomes. And then 13 of the centers included every single tested transplant patient. And so we use that data specifically to look at incidence rates. So we found that 24 patients at that time across those centers did test positive for COVID-19, which gives an overall incidence throughout that network of about 0.6%. And then of the tested patients specifically, a 4.4% positive rate. For the positive patients, trying to look at what did they present with, a little over half of them had any symptom reported, most commonly cough and fever, but also some GI symptoms were pretty significant as well. And then a quarter of the positive patients were identified incidentally, no symptoms, they were just admitted for some other procedure or some other reason. So when we look at the outcomes of the kidney transplant patients who were COVID positive, the large majority of them just had supportive care and nothing else needed to be done. Several of them had a reduction in their immunosuppression. The highest level of care, the most of them were outpatient or inpatient non-ICU setting. Specifically, the bottom two red rectangles here show what are the outcomes of the transplant themselves. So 20 of the 24 or 83% had no graft-related complications at all. There were 2 episodes of AKI and some rejection that was associated with these infections. And most importantly, how were the patients? So everybody recovered. So there was no reports within this cohort of any graft loss, no respiratory failure, nobody was intubated, and most importantly, no patients died as a result of COVID-19 during this time. So conclusions, we report that the pediatric kidney transplant patients appear similar to their non-immunosuppressed peers with regards to these good outcomes when infected with COVID-19. And really the second take-home message is that the learning health system structure that we had in place really allowed us to rapidly create this, the questions about COVID and link it to the data set that we had. And so from the time that I remember we had this quick meeting with just a couple of us to when we had this REDCap sent out was about 2 weeks. And so, you know, we can do this with any number of questions. And then we have a follow-up study in progress that our teams are putting in data from. So we have until the end of this month. We've asked centers to upload all their data from September 5th through February 28th and hope to put a second report out there. And then this, at the time that this study was published, this was the largest study of pediatric kidney transplant patients that we could tell, I think worldwide. So that's my talk. Thank you.
Thank you, Dr. Varnell. And the order is slightly different in the slides. So Dr. Shah, would you be ready to present?
Yes, I'm ready.
Thank you.
Thank you, Dr. Khan, for the introduction. So I would be talking about sex disparities in cardiovascular health in dialysis patients. So cardiovascular disease remains the leading cause of morbidity and mortality in patients who have kidney failure and are undergoing dialysis, and it contributes to about 50% of the deaths. And the risk of cardiovascular events is 10 to 20 times higher in dialysis patients as compared to the general population. So this is from this figure shows the risk of cardiovascular events with kidney disease, and as we can see, the risk increases with worsening of kidney function, with the highest incidence of cardiovascular events in patients whose GFR was less than 15 and who were undergoing dialysis. And this figure again shows the risk of cardiovascular events with progression of kidney disease. This is the data from one of the largest studies, which was performed from Kaiser database in California, again showing that the risk of cardiovascular events was highest in patients whose GFR was less than 15, basically forming the basis for my research proposal for the K-Scholar project. So one important thing is that there has been exclusion of women and patients with kidney disease in cardiovascular disease clinical trials. And this has created a knowledge gap in how cardiovascular disease health status differs between men and women with kidney failure. Additionally, despite 2/3 of dialysis patients having prevalent coronary artery disease, the method of coronary revascularization remains a matter of debate, and little is known about the patient experiences in decision support for revascularization treatment. So this, the background which I briefly discussed creates three important knowledge gaps. First knowledge gap is regarding sex differences in cardiovascular events and outcomes. There is no real data, and we really don't know if there are differences in cardiovascular health between men and women in patients who are undergoing dialysis. The next knowledge gap is about sex differences in treatment strategy and outcomes. And finally, there is also a knowledge gap in optimal treatment strategy for patients with acute coronary syndrome who are undergoing dialysis, whether they should receive CABG or they should receive PCI. So this forms the basis for the specific aim 1 of my research proposal for the K-Scholar project to examine sex differences in major adverse cardiovascular events defined by myocardial infarction, unstable angina, congestive heart failures, or stroke, and outcomes of patients with end-stage kidney disease. I would be sharing some of the preliminary data that we have so far. The project uses the USRDS data system, which actually includes all dialysis patients in the United States who are undergoing dialysis. We have a 9-year data, which is around 1 million patients, but this is a preliminary data from about 1 million, from around 100,000 patients. So we linked it to Medicare claims so that we could get information on their hospitalizations. So we had around 100,000 patients in our final cohort. We looked at these important covariates, which included age, race, ethnicity, BMI, whether they receive pre-dialysis nephrology care or not, comorbidities, including hypertension, diabetes, the type of dialysis modality, the type of dialysis access, and the other laboratory parameters like serum albumin and serum hemoglobin. These were the baseline characteristics. So overall, we had 55% men and around 45% women. The mean age was 70 years. Patients of white race and ethnicity were in the highest frequency, and majority of these patients received hemodialysis, which was about 94% in the study cohort. Next, we looked at distribution by age. So majority of patients were between 64 to 74 years of age, which was about 34%, followed by patients between 75 to 84 years of age, which was about 32%. So this figure shows the sex-based disparities in cardiovascular events. We looked at four big cardiovascular events, which is congestive heart failure, stroke, myocardial infarction, and angina. The bar in blue represents the frequency of events in men, and the orange bar represents frequency of cardiovascular events in women. So if we look, women had higher frequency of congestive heart failure as compared compared to men, which was 37% versus 33%. Similarly, women had higher frequency of stroke as compared to men. The frequency of myocardial infarction and angina was more or less similar in men and women. And overall, the frequency of cardiovascular events was higher in women, which was 42% as compared to 38% in men. So the prior slide showed the unadjusted frequency, and this one shows the adjusted hazards of the cardiovascular events, where we looked, and if we look at the adjusted hazards, overall, women had 17% higher likelihood, higher odds of having cardiovascular events as compared to men, and women had 28% higher odds of having stroke as compared to men. And if we look at the overall major adverse cardiovascular events, women had 16% higher odds of having cardiovascular events as compared to men. Thank you.
Thank you, Dr. Khan.
Shah.
Well, thank you, Dr. Khan, for the kind introduction. I'm excited to be talking about my work phenotyping infants at high risk for peanut allergy. Next slide. In 2015, the results of the Learning Early About Peanut Allergy study were published in the New England Journal of Medicine. This was a very large randomized controlled trial of 640 infants who are considered to be high risk for peanut allergy. And they were basically introduced peanut early. Well, half of them were introduced peanut early, and they were monitored for 5 years. And then the prevalence of peanut allergy was assessed in the cohort. And what they found was that there was a striking reduction in peanut allergy prevalence in the infants who were consuming peanut early and often in their diet. But one thing that isn't talked about in this study is that about 9% of infants who are screened for the study were actually not included because of peanut allergy that was already thought to be present. Next slide. And so in 2017, the NIAID convened an expert panel that published guidelines for the prevention of peanut allergy in the United States. And I'd like to focus your attention on Addendum Guideline 1, which is really targeted at infants with severe eczema and egg allergy or both diagnoses. And the recommendation is that the provider seeing the patient should now strongly consider evaluating the patient for the presence of allergic antibody to peanut prior to introduction, and that the oral introduction of peanut should occur by 4 to 6 months of age. And really, these guidelines actually represent a dramatic shift in our clinical practice, both as pediatricians and as allergists, because prior to 2008, the American Academy of Pediatrics had actually recommended delayed introduction of peanut. Sorry, can you go back? Prior to 2008, the American Academy of Pediatrics actually recommended delayed introduction of peanut to 3 years of age because they thought that, or the thought at that time was that that may prevent the peanut allergy outcome. And now here we are in 2017, knowing that really earlier introduction is going to serve as a means of prevention. And in particular for allergists, where this really is a practice-changing recommendation, is that it does recommend we screen patients prior to the introduction of the food. Next slide. So we traditionally make a peanut allergy or a food allergy diagnosis largely based on the patient's history, and we confirm it with testing that indicates the presence of allergic antibody to the particular food. We use skin prick testing or serum-specific IgE testing. Neither of these tests are perfect. Skin prick testing has poor positive predictive value, and it's very dependent on the patient's history as well as other both patient and individual performing the test factors. Serum-specific IgE testing is less sensitive than skin prick testing, and oral food challenge testing, which is sort of currently the standard for diagnosis of any food allergy, really takes quite a bit of time. It takes 3 to 5 hours. It costs money. It requires one-on-one nursing as well as the presence of a provider to evaluate the patient and treat the patient if a reaction is occurring. And it does have considerable risk. And when we talk about doing this in the infant population, as you can imagine, it becomes even more challenging because changes need to be made to how the test is done as well as how we assess the patients. So I really say all of this because I want to sort of highlight the fact that there's really a need for improved diagnostics in food allergy research. Next slide. So during my fellowship, I performed an exploratory pilot study looking at differential gene expression in the whole blood of infants who are high risk for peanut allergy. And I recruited 20 infants prospectively from the allergy clinic at my fellowship institution who underwent routine clinical procedures for evaluation of peanut allergy. And then based on those procedure outcomes were designated as peanut non-allergic, peanut sensitized but tolerant, or peanut allergic. Next slide. And when we looked at the whole blood transcriptome of these infants, what we found is that differential gene expression was present between these three groups, but the fold changes really weren't that robust. And when we looked at the genes were really none that had been previously well described in the context of food allergy. So it was really quickly obvious to us that differential gene expression in the whole blood was probably not going to be a sensitive or specific enough tool for the identification of peanut allergy. But this work did lead me to the development of the aims of my ongoing work. Next slide. So we know that CD4 T cells play a critical role in the pathogenesis of food allergy. Studies have shown that this cell population may have some functional deficiencies in patients who go on to develop food allergy or have food allergy. In particular, patients who go on to develop food allergy, their CD4 T cells have been shown to have reduced proliferation with non-specific stimulation, and then a decrease in the upregulation of particular genes following non-specific activation. And when we look at allergen-specific CD4 T cells and we activate them with allergen, particular cytokines are produced, and some studies have shown that this cytokine expression may play a role in distinguishing those with food allergy. Next slide. So the focus of my ongoing work is looking at examining the CD4 T cell transcriptome at baseline and after experimental stimulation with peanuts in infants at high risk for peanut allergy. The work is ongoing, and I hope in the coming months that I will actually be able to share some more of this data with you. Next slide. So in addition to my research interests, my clinical passion does lie in the care of these infants and their families. I've cared for these patients and their families for the past few years. And in particular, in the context of the recent guideline changes, I've found that there's a lot of anxiety surrounding allergenic food introduction. And just in talking with families, a lot of people will say, you know, I introduced peanut to my child in the parking lot of the pediatrician's office prior to their well child check before they came in case a reaction were to occur. And so with this in mind, I developed the beginning introductions to allergens early clinic here at Cincinnati Children's, and it occurs on the first and third Thursday afternoons here at Children's. I am targeting 4 to 11-month-old patients for the clinic who have eczema or concern about any food allergy or adverse food reactions. And in this clinic, I formally evaluate the infants, and I basically just provide an environment in which these families can talk to an allergy provider about their infant food allergy and feeding concerns. Next slide. I want to take a moment to thank everyone involved, in particular my mentorship team, Dr. Katya and Dr. Rothenberg and Dr. Zasad. Thank you.
Thank you, Dr. Devonshire. Dr. Jones?
Yes, thank you. Hi, I'm Laquita. I am an assistant professor in the Division of Oncology at Children's, as has already been mentioned. So I'm talking to you today about my KL2 project, actually, which is entitled A Novel Resistance Mechanism of Refractory and Relapsed FLT3 Mutant AML. Next slide. So just to start out with a little bit of background, AML is acute myeloid leukemia. It's actually the most common acute leukemia in adults and the second most common pediatric acute leukemia. And it can arise in a few different situations. So it can actually arise following an underlying hematologic disorder, for example, myelodysplastic syndrome or MDS. It can also happen following an MPN. In addition, it can occur following our previous chemotherapy. So we use chemotherapy often, obviously, to treat our cancer patients, but unfortunately, some of those chemotherapies predispose them to AML. In addition, it can occur in patients who've been previously healthy, in which case we call it de novo AML. But in terms of the pathogenesis is related to abnormal proliferation and differentiation of myeloid stem cells. Next slide. Next point. Okay, so in terms of the clinical manifestations, they're related to the fact that the leukemic blasts actually take over the bone marrow. So the patients at the time of presentation will usually have things like anemia, thrombocytopenia, as well as infection. Next point. In terms of the classification of AML, this has evolved over time, but currently we include things like immunophenotyping, which is basically a reflection of the cell surface markers on the leukemic blasts. We also include morphology in terms of how we classify AML, in addition to genetics and molecular features, which is where FLT3 is actually relevant, which I'll talk more about later on. And then finally, we do look at clinical presentation. So FLT3, or FMS-like tyrosine kinase 3, is one of the most commonly mutated genes in AML. So in general, for our patients who have AML, the treatment includes chemotherapy. It can include targeted agents like FLT3 inhibitors, which I'll talk more about. And then finally, it can also include stem cell transplantation. Next point. Unfortunately, for AML, there is about a 30% relapse rate. So we know that there is still work to be done to improve the outcome of these patients. Next point. So just to talk about FLT3 a little bit, FLT3 is actually present on normal blood cells, but unfortunately, the functionality of FLT3 is hijacked by leukemic cells. So in terms of the normal functionality of FLT3, typically it binds to its ligand, which is depicted here on the right. And as a result of binding to FLT3 ligand, there's homodimerization of the FLT3 receptor and subsequently downstream signaling through multiple effector pathways, including PI3 kinase, JAK-STAT5, and then also RAS. So that leads to growth, proliferation, and survival of the hematopoietic progenitor cells. But that functionality is hijacked by the leukemia cells. Next point. The mutations that occur in patients take on two different forms. Next point. The first and most common form is actually the internal tandem duplications that occur in about 15 to 20% of our AML patients. And basically this mutation disrupts the autoinhibitory function, or the brake that's sort of built into FLT3 in the normal state. Next point. In addition, there are tyrosine kinase domain mutations that occur, and these are missense mutations that ultimately lead to hyperactivation of FLT3. And they occur both in de novo AML, but then also in relapsed patients who've previously been treated with FLT3 inhibitors. I'm particularly interested in the phenylalanine to leucine at position 691 mutation, or F691L mutation, which occurs in about 12% of patients following FLT3-directed therapy. Next slide. So I just wanted to highlight a little bit of the work that I've done during my time as a KL2 scholar, just to show you that this particular mutant is actually quite resistant to our FLT3 inhibitors, including our preclinical inhibitor, which is NCGC 1481, and then also it's resistant to gilteritinib, which is an FDA-approved FLT3 inhibitor. So you can see here on the left panel that basically these inhibitors bind to FLT3 when it has an F691L mutation. And also they lead to decreased canonical FLT3 and STAT5 signaling, but that does not translate to an increase in the amount of cell death for the FLT3 F691L mutant. And also, despite the fact that canonical signaling is blocked in the FLT3 F691L mutant, they can still form colonies. So in other words, what that means is that the FLT3 signaling is blocked, but unfortunately, those leukemic clones that are exposed to these FLT3 inhibitors continue to propagate leukemia. Next point. As depicted here on the right side of the slide, you can also see that the mice that are treated with these various inhibitors actually die despite the fact that they're getting treated with FLT3 inhibitors. So in the context of FLT3 ITD, 1481, which is our novel FLT3 inhibitor, actually does prolong survival. But in the case of FLT3 F691L, you can see here that the mice unfortunately succumb to disease despite the fact that they're being treated with 1481 or gilteritinib. Next slide. But contrarily, when we disrupt the functionality of FLT3 with a genetic mechanism, particularly we used an shRNA that targeted FLT3, which was doxycycline inducible, we can see here that FLT3 and STAT5 actually go away, and that does lead to a reduction in viability both in FLT3 ITD as well as FLT3 F691L. But that's different than what we see with the pharmacologic inhibition. So as depicted here with the pink lines, you can see here that pharmacologically inhibiting FLT3 with 1481 and gilteritinib and FLT3 ITD leads to a reduction in viability. However, FLT3 F691L is relatively resistant despite the fact that we're using pharmacologic inhibition. Next slide. So in summary, pharmacologic FLT3 inhibition does lead to a reduction in canonical FLT3 signaling in FLT3 F691L, but that does not, however, translate into an increase in cell death of the leukemic blasts. It also does not result in a reduction in clonogenicity. In addition to that, xenografts with FLT3 F691L unfortunately die despite being treated with FLT3 inhibitors. Next point. Contrarily, when we disrupt FLT3 using a genetic approach, that does lead to a reduction in viability, it does lead to cell death, and it also leads to reduction in clonogenicity, which I've not shown you. And finally, importantly, we do see a prolongation of xenograft survival when we disrupt FLT3 genetically. Next slide. So based on all of that information, in summary, I just wanted to point out that we are supposing that or hypothesizing that there is a kinase-independent mechanism of resistance in FLT3 F691L. So if we could focus a little bit in on the middle portion of this slide, you can see here that when FLT3 ITD is present and you expose the cells to FLT3 inhibitor, there is a reduction in canonical FLT3 signaling, ultimately leading to death of the leukemic blasts. Unfortunately, when F691L is present, we're saying that those same pathways are inhibited, but there's something else that's present that's allowing the cells to survive, despite the fact that canonical signaling is blocked. So we're supposing that there is a kinase-independent mechanism of resistance that's present, leading to AML cell survival. Next slide. So moving forward, we would like to generate a kinase-dead version of these FLT3 mutants. In addition, we would like to understand more about the molecular basis of the kinase-independent signaling that we're proposing. And then importantly, obviously, the main goal here is to improve outcomes for these patients. So we would like to test sensitizing these FLT3 F691L mutants to FLT3 inhibitor therapy by targeting those relevant protein complexes using various genetic approaches, which we hope would inform clinical trial development in the future. That's it. Thank you so much.
Thank you, Dr. Jones. Last but not least, Dr. Perazo.
Hey, everyone. I'm going to be talking about the pilot test that I did for the KL2 program, which is a test of pathway to health, an intervention bundle to improve care linkage and retention in people with HIV. Slide. Okay, so just a bit of a background on the current state of the science of HIV. About 1.2 million are currently diagnosed. Antiretroviral therapies made it possible to achieve viral suppression or an undetectable viral load that is extremely common now and occurs quite quickly after people start HIV treatment. In addition to the individual benefits to the patient, ongoing international research, large clinical trials such as the HIV Prevention Trials Network have provided strong evidence that HIV treatment is going to help society because it is going to not only help the person who is affected, but it is going to decrease the likelihood of transmission. And so this is known as treatment as prevention. Current data on HIV care indicate that we still have about a quarter of the people that are diagnosed who don't receive any care at all. So this means that they may have a diagnosis, but there is no record of them ever actually entering the care environment. Nearly half were not successfully retained in care long-term in the first year especially. And then 35% are not achieving that undetectable viral load and sustaining it. Slide. So with this information over the last several years since I became a faculty member, I started to develop the intervention that I tested, which is the Pathway to Health intervention. I did a lot of qualitative research. I worked with people who live with HIV. I worked with the Caracol House case management team, which for those that are not familiar, Caracol is a company here, or is an organization here in Cincinnati who does case management and housing services for people who live with HIV and have been doing so since the early days of the HIV pandemic, where they actually would have people with HIV live in I don't want to call it inpatient, it was a residential setting. And then also working with the UC Infectious Disease Center's physicians and nurses, doing qualitative interviews and focus groups to understand and learn their side of things. So getting a holistic perspective, working with the patients and the people who work with them about what needs to be present at the beginning of care. And so using that information that I got from them, I combined evidence-based strategies that are actually 1A, as they call it, evidence. They have been done by large research teams throughout the United States and have been published as the best practices when it comes to working with people with HIV. But they've largely been tested and implemented in isolation. And this includes, if you look at the table, strengths-based case management, intensive outreach, and patient navigation. These have all been done in different interventions, which are listed in the very far right column. Those are the different studies that have been done. And no one has yet tested them together, used all of these theoretical frameworks and interventions together. So part of it was doing pre-visit and pre-engagement contact with patients was part of the intensive outreach and patient navigation processes, and then using strengths-based case management approach using telehealth and internet resources. So being able to get basic assessment and data collection on the patient, not just an appointment reminder and the absolutes, as they were called, that are needed for them to get an appointment through central scheduling. We wanted to actually touch base with them and see how they are doing and be able to tailor our care approach based on their individual needs. And then also doing, throughout the first year of care, regular outreach to determine any changes in their status. So what are some of the characteristics of the intervention? We did pre-visit telehealth calls, and then up to 7 total calls, follow-up calls after key visits. The key visits, there are more visits for HIV patients that, like many different conditions, at the very beginning of care. While they're trying to actually assess disease progression and things like that, they might have 3 to 4 visits at the beginning of their care. And then today, HIV care is often, in the long term, once every 6 months to once a year that they come in for care. We designed a telehealth assessment that can be done by nurses, and actually I'm able, in this implementation science course, to make the argument that a social worker or case manager, depending on the nature of the practice that it might be implemented in, if it's found efficacious, to assess their general well-being, physical and mental health, just basic symptoms, their safety, their medication adherence and issues, any transportation and psychosocial issues they have. And then the real benefit we've seen is that we are able to prepare and deploy resources based on their individual needs before they come to the care environment, whereas before this is something that was assessed as part of their intake once they were there, but that is further delay before they might have healthcare coverage. It's further delay before they might have housing. It's further delay that we can prevent by doing this intervention prior to them showing up in care. We also gave them access to Positive Peers, which is an evidence-based online community that is HRSA funded. Next slide, please. So the KL2 Scholar Project is a pilot study that I've recently completed data collection on. It is a smaller project in scope than I originally planned, and that is largely due to the same interruptions that other people have had, as well as a leave of absence. I ended up with 40 people living with HIV, 20 that went into an intervention group, and 20 that went into a standard of care group that was done by retrospective chart review. This scholarly project was used to look at the feasibility and acceptability. These are currently in process right now. I'm actually collecting the data on how people felt about the intervention. And then to be able to find some data trends or hopefully some initial efficacy was my goal there. But I knew that with the small sample size, it may be difficult. So the endpoints, my primary endpoint was, did the intervention give any sort of improvement to the time that it took for a patient to become undetectable? Often interruptions to treatment are one of the or failure to actually present to treatment are some of the key reasons people don't reach undetectable in a timely manner. Also, a poor relationship with the healthcare team or healthcare providers has been known to delay people being able to reach undetectable HIV status. Secondary endpoints include the time it takes them between contacting us and to get to their baseline visit, their time to starting their meds, their time or the number of missed visits they have, and then I'm also going to be looking at different changes in psychosocial variables within the pathway to health group that I measured as part of the intervention. The analyses included group comparison of median days to undetectable status. Because of the large range and certain major outliers in viral load, we used a median comparison, and chi-score analyses to determine the impact of their group assignment on primary and secondary endpoints. And then you just have some descriptives in this table that just basically show that there were no significant differences. I did do a group comparison test. There were no significant differences for any of these variables at baseline. Next slide, please. So what were some of the key findings? And I'm also going to talk about what my next steps are. A lot of these were not statistically significant, so I will say that up front. But the Pathway to Health group had a lower median number of days to undetectable HIV status, and it was 58 versus 91.5 days to undetectable. In a sample of 32 of the patients of the 40 actually reached undetectable during the study period, but that was not a statistically significant result on the median test. All of the Pathway to Health groups presented to an intake visit, whereas 80% of the standard of care group did. There were, I believe, 2 people that never presented to care in that group. 90% of the Pathway to Health group were able to present to care within 14 days versus 65%. What that approached significance, but was not considered statistically significant based on the 0.05 p-value alpha. 90% of the Pathway to Health group reached undetectable during the study period at all. So this particular variable was, is this a person who reaches undetectable versus 70% of the standard of care group. Most of the, about 95% of Pathway to Health reached undetectable by 6 months, which was actually a best practice indicator. Usually people reach undetectable far before that, but it, of course, it does not, it really depends on where you're starting out with your viral load, you know what I mean? So it's really hard to make a perfect comparison between the participants versus 80% of the standard of care. And then there was a statistically significant result showing that the Pathway to Health group had both fewer no-shows and greater completed visits during the study period. So what are my next steps? Well, I obviously need, in order for this to ever get to the implementation phase, this particular intervention bundle would need to be shown to be efficacious. So I want to refine the intervention, go for R series research funding in order to do a fully powered clinical trial, which will be my next step. And then definitely want to eventually work toward, and if you know, I'm able to refine it to a point of efficacy, want to implement it as widely as possible, because I think it does actually bring in a lot of, it's a pragmatic way of bringing in a lot of different evidence-based strategies. And that's all I have for you. So thank you.
Thank you so much. Well, thanks to all of our presenters. I think you can see that this is an incredibly impressive group of junior investigators. Each of them did a phenomenal job presenting their work. So congratulations to all of them. You can see why Jason and Krista and I find it a tremendous privilege to be able to work with this program. They're amazing scholars.